and it will be moderated by Dr. Manoj Mukherjee sir, and other panelists are Dr. Devanshu Ghosh, and Dr. Shantanu Sheth, and Dr. Soumitra Ghosh.
So, good afternoon. So, is there any extra memory? MS Porikhar age all are filled up. But you have to purchase extra space from Google or any sources. You need it. So, carcinoma of larynx. It's a very important topic for MS examination. Different questions are there, starting from very basics to higher level. So, we will try to restrict our discussion in basic level and mainly the reasoning part, and on the question answer part, which will be answered in your practical exam, which you will be asked in your practical exam. So, our objectives, it will be an interactive discussion, just question answer pattern, and through that discussion we will cover all the basic things. So, what is written there? It's not clear, it's my handwriting, it's not clear, but our objectives are very clear. We will discuss the basic things here. So, virtual case of carcinoma larynx, I will ask third year PGT Dr. Suhotro to present the virtual case. Please come.
So, this is a 58-year-old male patient who is a farmer by occupation, resident of Katwa, Purbo Bardhaman, religion Islam, marital status is married and belonging to the lower middle socio-economic status. So, he presented to the ENT OPD with chief complaints of change of voice for 1 year and difficulty in breathing for the last 2 weeks. In history of present illness, the patient was apparently well 1 year back when he developed a change in his voice, which was insidious in onset and had a hoarse character, that is a rough and husky voice. The hoarseness is gradually worsening for the past 1 year and is present throughout the day. Now, the hoarseness is occasionally associated with a productive cough, but the sputum was not blood tinged. The hoarseness worsens in the evening and there are no relieving factors. So, the hoarseness was also associated with a difficulty in breathing for the last 2 weeks, which was initially mild and noisy. It is gradually progressive and present throughout the day and night. It is present even at rest and is not associated with any change in position. And there is no history of chest pain. Now, the other important negative histories include there was no fever, pain while speaking, voice abuse, neck trauma, neck surgery, radiotherapy, choking episodes, earache, neck mass, and regurgitation of food. All of these were not present. So, coming to the history of past illness, there are no similar history in the past, and he is a known hypertensive for the last 7 years and type 2 diabetes mellitus for the last 5 years. He has no history of any major surgery, tuberculosis or any thyroid disorders, and he has no history of any drug allergy. Coming to the personal history, he has a mixed diet and his appetite has been reduced for the last 1 month. The bladder and bowel habits are normal and his sleep is disturbed due to the breathing difficulty. Now, the important point to note here that his addictions include that he smokes 8 to 9 BDs per day for the last 30 years and he has been an oral tobacco abuser for the same duration. So, coming to the treatment history, he is on amlodipine 5 milligrams for his hypertension and on metformin 500 milligram twice daily for his diabetes. And an important history is that he has no history of any radiotherapy. So, there is nothing significant in family history. Coming to the general physical examination, he is conscious and alert. He has a decubitus of choice. He is moderately built and nourished. Pulse is 82 per minute and is regular of normal volume with no radioradial or radiofemoral delay. Blood pressure is 130 upon 80 millimeters of mercury and the respiratory rate was 22 per minute of an abdominothoracic pattern. He was afebrile and there was no pallor, icterus, cyanosis, clubbing or pedal edema. The cranial nerve functions were within normal limit. The neck veins were not engorged and the neck glands were not palpable. Coming to the systemic examination, the important thing to note here is that he had bilateral vesicular breath sounds on auscultation of the chest, and there were additional sounds present during both inspiration and expiration. Coming to the local examination, his oral cavity had black stains over the teeth and gums with a poor oral hygiene. The oropharynx was apparently normal. The indirect laryngoscopy showed an extensive exophytic growth which involved the right vocal cord, and it was compromising the glottic chink and was extending to the right vestibular fold. The right hemilarynx was fixed. The epiglottis, bilateral valleculae and the left hemilarynx appear normal. Coming to the neck, the trachea was in a central position. The laryngeal framework was normal. The laryngeal crepitus was present, and the tenderness of the larynx was only present during movements of the larynx, and the neck nodes were not palpable. So coming to the local examination of the ear and the nose, there was nothing significant abnormality found. So coming to the summary, he is a 58-year-old married Muslim patient, farmer by occupation, belonging to the lower middle socio-economic class, a resident of Katwa, Purbo Bardhaman, who presented with the complaints of change of voice for 1 year and difficulty in breathing for the past 2 weeks. The voice was hoarse, present throughout the day and worsened in the evenings. And it was occasionally associated with productive cough. The patient had stridor for the past 2 weeks, which is present even at rest. There is no history of fever, pain while speaking, voice abuse, neck trauma, neck surgery, radiotherapy, choking episodes, earache, neck mass, regurgitation of food. He is a hypertensive and diabetic and is receiving regular treatment for both. He is a known bidi smoker and oral tobacco abuser. He has no history of any drug allergy and no significant family history. On examination, an extensive growth was found involving the right hemilarynx with no movement. No neck swelling was, or neck nodes were palpable. Laryngeal crepitus was present. Laryngeal tenderness present only during movement of the larynx. He had no significant ear or nose abnormality. On chest auscultation, sounds could be heard during both inspiration and expiration. Otherwise, the systemic examination was normal. So coming to the provisional diagnosis, it is a transglottic growth of the larynx, possibly neoplastic, with a clinical staging of T3N0M0, which belongs to stage 3.
Thank you, Dr. Shivot. Please have your seat. Yeah. So, any comment regarding that thing, the staging of the disease? Hey, mic ta ke debe? Mic to dik debe, ha? Dewa ache na? So, Dr. Akash, stage 3. How can we say it's stage 3?
So it has involved the paraglottic space, sir. So leading to fixation of one of the vocal cords due to thyroiditis muscle involvement, sir. And
how can you say the paraglottic space is involved?
Hemilarynx fixation, sir, is present.
Is it possible to say paraglottic involvement without imaging?
No.
No. So you can do the staging only by clinical examination also. It is fixed. Please have your seat. It is fixed. When it is fixed, it is at least stage 3, if not 4, at least stage 3. And for involvement of the paraglottic or pre-epiglottic stage, you have to take the help of imaging. Otherwise, you can't say it clearly. ওখানে এই ওকে মাইক দাও না কি বলছে
স্যার এখানে ট্রান্সগ্লটিক বলা হয়েছে কিন্তু আমাদের ফাইন্ডিংস ছিল ওখানে তো শুধু ভোকাল কর্ড আর উপরের পর্যন্ত তাহলে আমরা এটাকে সুপ্রাগ্লটিক বা গ্লটিক
প্রবাবলি ভেস্টিবুলার ফোল্ড একটা কিছু মেনশন ছিল কি ভেস্টিবুলার ফোল্ড ওয়াজ দ্য ভেরি গুড থিং হোয়াট ইজ ট্রান্সগ্লটিক গ্রোথ হোয়াট ইজ ট্রান্সগ্লটিক গ্রোথ
ইনভলভিং সুপ্রাগ্লটিস গ্লটিস অ্যান্ড সাবগ্লটিস
এনিওয়ান সামনে কে বসে আছে তুমি কি নাম অমৃতা না বলো হোয়াট ইজ ট্রান্সগ্লটিক গ্রোথ তুমি যেটাই বলবে সেটা তোমাকে এক্সপ্লেন করতে হবে হ্যাঁ দ্যাট ইজ ইউর প্র্যাকটিক্যাল এক্সাম
Was the glottis and the ventricles superiorly?
glottis and
The ventricles and inferiorly subglottis.
very good you have to define all the very specifically মানে একদম এক্সাক্ট যেটা বলা সেটা বলতে হবে it is transglottic when it crosses the ventricles vertically any growth crossing the ventricles vertically is transglottic তিনটে রিজিয়নই ইনভলভ করতে হবে এরকম নয় দুটো রিজিয়ন ইনভলভ করলেও ইটস ট্রান্সগ্লটিক by definition crossing the ventricles vertically so transglottic growth so very basic thing what is the subdivisions of larynx anyone can say what are the major parts of larynx it's a very undergraduate question how can you say what is the level of supraglottis
It's from the tip of the
epiglottis
to
সবাই জানে নিচে
upper part of the true vocal cord.
upper part of true vocal cord anyone false vocal cord upper part of false vocal cord anyone okay dao okay mic ta
Sir, epiglottis to the horizontal plane passing through the ventricle and true vocal cords.
passing through the ventricle so it will be explained why passing through the ventricle so horizontal line passing through the lateral margin of ventricle where it meets with the superior surface of vocal cord in ms exam you have to be little bit of perfectionist arektu mane perfectly bolte hoy not the undergraduate answer so horizontal line passing through the lateral limit of the ventricle where it meets the superior surface of vocal cord it's not the vocal cord it's not the vestibular fold it's a line horizontal line তার নিচেটা glottic area উপরটা supraglottic that line does not always pass through the superior surface of the vocal cord and the lower limit of the glottis
1 centimeter below the
1 centimeter just 1 centimeter below the previous line so surface anatomy you all know that thing extent of the larynx a very undergraduate question radiologically it is একদম লাস্ট বেঞ্চে ও কি বলছিল বলো রেডিওলজিক্যালি larynx radiologically larynx extends from tip of the epiglottis কোন জায়গায় থাকে C4 to C6 tip of the epiglottis at the level of lower border of the C2 and cricoid C6 and you have to know all the basic anatomy supraglottis what are the parts of subsides of supraglottis glottis subglottis preepiglottic and paraglottic space can you say what are the parts of glottis subsides of glottis okay mic ta dao glottis very simple undergraduate question what are the subsides of glottis
So true vocal fold and the false vocal fold, sir.
false vocal fold glottis basic এ ভুল করে ফেললে খুব মুশকিল it's a very basic undergraduate question তুমি বলো what are the parts of glottis mic
So the true vocal cord, it is basically from the in vertically it is basically from the superior border of the true vocal cord up to the 1 centimeter level below, and area adjacent to it is basically the glottis.
it is the vocal cord,
Vocal cord.
superior and inferior surface,
surface.
both surface, anterior commissure and posterior commissure. Nothing more, nothing less. Be very specific. Vocal cord, superior and inferior surface, anterior commissure, posterior commissure. ঠিক আছে? This is a glottis. এগুলো কিন্তু একদম বেসিক কোশ্চেন I am not supposed to discuss here. একদম বেসিক কোশ্চেন এগুলো কিন্তু একদম ভুল করা যাবে না ল্যারিংসের এগুলো। সো ইকুয়ালি প্রি এপিগ্লটিক প্যারাগ্লটিক স্পেস এগুলো একটু দেখে নেবে এগুলো এত ডিসকাস করতে গেলে এখানে হবে না সো সাবডিভিশন লাইন এ যেটা বলা হয়েছিল হরাইজন্টাল প্লেন ফ্রম দ্য ল্যাটারাল মার্জিন অফ দ্য ভেন্ট্রিকল হোয়ার ইট মিটস দ্য সুপেরিয়র সারফেস অফ দ্য ভোকাল কর্ড অ্যান্ড লাইন বি 10 millimeter below the first line in between glottis below is the subglottis up to the inferior border of the cricoid and above is the supraglottis subsides epiglottis, both suprahyoid and infrahyoid epiglottis. So why it is divided in two parts, epiglottis, infrahyoid and suprahyoid? What is the importance? Bolo, mic now.
In case of suprahyoid epiglottis, the tumor will be more exophytic, and in case of infrahyoid epiglottis, tumor will be infiltrative.
Yeah, and another thing is that pre-epiglottic space in contact with the infrahyoid epiglottis. Pre-epiglottis, that is very important for carcinoma larynx. So laryngeal surface A folds, arytenoids and the vestibular folds. Subglottis below the line hoye gelo, laryngeal ventricle. It belongs to which part? Supraglottis or glottis? It belongs to supraglottis. Laryngeal ventricle belongs to supraglottis. This is embryologically significant, embryologically determined. I will tell you. So what is the embryological significance of larynx? Anyone, just two lines, describe the development of larynx in two lines. কে বলবে? সুহত্র আর পেছনে কারা আছে? It develops from both the respiratory and digestive. Digestive কোন পার্টটা? larynxের কোন পার্টটা digestive সিস্টেমের? Supraglottis. It's arch 2 and 4. Arch 2 and 4, that is supraglottis, and lower part 6th. Right? That is the respiratory. So it develops from both the digestive and respiratory. And the line of division is the ventricle. So the upper part goes in line with the vallecula, tongue, all this line. So any growth of the supraglottis can spread upward very easily, and any growth of the glottis, as it is a part of the respiratory system, it will go down and laterally. বোঝা গেল? গ্লটিক গ্রোথ সাধারণত উপরের দিকে যাবে না, পরে ইনফিল্ট্রেট করে অনেক যেতেই পারে, বাট glottic growth will go downwards and laterally, and supraglottic will go easily towards the tongue base.
What is the subsides are different. As a whole, as a result of the treatment approach is also different of the supraglottis, glottis and subglottis. Okay, that is the clinical importance of knowing the embryology, and these lines are called watershed line of the larynx.
So this is the question will is frequently asked in MS exam, not in the undergraduate. MS exam, what is the embryological significance of larynx in context of carcinoma? একটা তো ডেভেলপমেন্ট বলা হলো এখানে, সুপ্রাগ্লটিস আর্চ 2, 4, আর্চ 7, রেসপিরেটরি ডিভিশন, ল্যাটারালি ভেন্ট্রিকল হয়ে গেল। নেক্সট ইজ দ্য কনটেক্সট অফ কার্সিনোমা, ভোকাল কর্ড ইজ দ্য ওয়াটারশেড লাইন, লিস্ট লিম্ফ্যাটিক ড্রেনেজ, তাই তো? ওপরে লিম্ফ্যাটিক বেশি, নিচে লিম্ফ্যাটিক কম। And the level 1, level 2 supraglottis will drain to the level 2 and 3, glottis, subglottis level 4 and 6, supraglottic carcinoma spread করবে upward, glottic downward. এগুলো সব তোমাদের দিয়ে দেওয়া হবে। What is transglottic carcinoma? Already described. And what are the routes of spread of carcinoma within larynx? Say there is a initial growth in the vocal cord or in the vestibular fold. How will it spread within the larynx? How will it go in different part of the larynx? Anyone? How will it spread in different parts of the larynx, or how will it become the extralaryngeal?
তিনটে area growth কিন্তু different, growth pattern and spread. Supraglottis,
pattern.
glottis, subglottis.
Yeah? Erosion of thyroid cartilage, yeah, that is going beyond the larynx, but within the larynx, pre-epiglottic, paraglottic space, very good. So, transglottic to bole dewa hoyeche, there is 4 ways of spread of the carcinoma larynx. Crossing the ventricles directly, it can go to other side, through the anterior commissure, through the paraglottic space, and posteriorly along the arytenoid cartilage. Within the larynx, it can spread these 4 ways. And through the anterior commissure, always remember anterior commissure is a very tough structure. No cancer can invade the anterior commissure, because the anterior commissure ligaments are attached there, and these are the very tough structure. So growth of the vocal cord either have to go above the anterior commissure and go through the area where the thyroepiglottic ligament is attached, that is the petiole of the epiglottis, or you have to go down to the anterior commissure and spread either way.
But another downside of this, স্যার যেটা বললেন, anterior commissure tendon is a very tough structure, but the fallacy is that যখন এটা involved হবে, that act as a conduit of the spread to the pre-epiglottic space. সামনে রয়েছে anterior commissure. Okay, কেন হবে? Because anterior commissure the area there is a devoid of inner perichondrium of the thyroid cartilage. ওখানটা থাকে না perichondrium.
তো বেসিক কিছু অ্যানাটমি একটু ভালো করে জেনে রাখতে হবে। হাউ দ্য গ্রোথ অফ দ্য প্রি এপিগ্লটিক স্পেস কাম টু দ্য প্যারাগ্লটিক স্পেস, হোয়াট ইজ দ্য কনফ্লুয়েন্স বলতে পারবে? হাউ দ্য প্রি এপিগ্লটিক দ্যাট কামস টু দ্য প্যারাগ্লটিক স্পেস? ইয়া, প্রি এপিগ্লটিক anteriorly there is epiglottis is coming down and narrow, and in both sides is open to continuous with the paraglottic space. So assessment of index subside from the history and disease progression, it's a very simple thing. From the history, যেমন এই পেশেন্টটা ছিল, it started with the hoarseness of voice, so the growth in glottis. If it presents with a lump sensation or hot potato voice, growth in supraglottis. So supraglottic carcinoma, these are the features. Glottic carcinoma, hoarseness of voice. Subglottic also, globus and early stridor, subglottis. And there may be due to METs or neck SOL. Disease load, egulo theoretical. Patient profile, you all know it. Risk factors, you all know this is the tobacco, smoking, but which part of the tobacco? Which component of the tobacco is important? That is benzopyrene and hydrocarbon. Don't forget to mention the HPV virus. Any that head neck cancer, any head neck carcinoma, in risk factor it is called happy time cancer. Right? Happy time cancer, if you are having the alcohol, smoking and HPV, that is oral sex. So any head neck cancer is the happy time cancer. So examination, a very important, very basic thing, and that will be described.
Patient started with a hoarseness of voice for 1 year. After that, difficulty in breathing started. What does it indicate? If we try to post it in a temporal sequence, কি indicate করে? Common sense. Indicate করে? Probably there are something blockage or growth in the laryngeal airway, or that has come to the hoarseness of voice, laryngeal, that has come to the sideways into the foot passage. That is the pyriform sinus. That is the temporal relation. আবার ধর আরেকটা পেশেন্টের প্রথমে দিল difficulty in swallowing or stickiness in the throat. আবার এক বছর পরে শুরু হলো কি respiratory distress. What does it indicate? Probably the epicenter, স্যার যেটা বলছেন, কোথা থেকে শুরু হলো? Probably epicenter was in the pyriform sinus or foot passage or anywhere in the hypopharynx that encroach into the larynx. সেই টেম্পোরাল সিকোয়েন্সটা কিন্তু অনেক সময় এই ল্যারিংস আর হাইপোফারিংসের কেসে বোঝা যায় না। ফ্রম হিস্ট্রি অ্যান্ড এক্সামিনেশন, পার্টিকুলারলি ফ্রম দ্য হিস্ট্রি, ইট ইজ ভেরি ভেরি ইম্পর্টেন্ট।
ডক্টর শান্তনু শীত।
Good afternoon. I will go through fast and just points which is basically come to the questions, okay? It is basically a long case, okay? And the long case is discussed by him. The problem is that when you see the case discussed, we come from the examination part, that is the clinical examination part, where we starts from the general survey. Now I want to point out some points he has mentioned, that this is a mainly a low socioeconomic conditions patient, okay, normally they are not a very high profile patients, they are low down patients, and they come to you when there is a very high chances because of a very poor build, nutritionally poor. These are the points you should mention in the general survey. That is not mentioned. So these are the things you should mention, is the build and the nutritions. Any examiner will first try to point out is that it written that is not or not. Okay, so very careful about that when you're writing a long case. The build and nutritions are normally not that very good in those sort of patients. So that is the point they will check out in the general survey. Second thing is that vitals may not be normal. Vitals may not be normal because this patient is having a respiratory distress for a prolonged time. Now the respiratory rate cannot be 22. Okay, that is the thing the examiner will take a note about. If you're writing a patient of a respiratory difficulty for more than 1 year or 3 months or 6 months, but you are telling the respiratory rate is 22 only, then that is the problem. That means you are not properly examining the patient. That is, without seeing the patient, the examiner will know that. Second thing is that if the lesion is the vocal cord lesions or the supraglottic lesions involving the posterior cricoid or in the posterior pharyngeal wall, the patient will develop a dysphagia. And this dysphagia patient will have a poor nutrition and the patient will have a less PP. The blood pressure will not be normal like that, okay? And the pulse will be more. So these are the things, vitals will change. And you have to be very careful when you are taking a case of CA larynx and you are telling this is a stage 3 cancer, but your vitals are very much normal. This is not going to be happen, okay? So be careful about that. Now, regarding the examination, this is the general survey part, and come to the local examination. First, we can divide the examination into 3 parts: oral cavity, oropharynx, and larynx and neck. Okay? By writing down, we can divide it into 3 parts. So first, we go to the local examination of the oral cavity. These are the points. So first thing is the inspection of the oral cavity. This is very important. Starts from the lip. And the things I write down here is the points you have to mention, even though these are the normals. Okay? Maybe they are normal, but you have to mention all these points. Now tell me what is here written lateral gutter. What is lateral gutter? Anyone? These are the points you may not know. What is lateral gutter? And what is gingiobuccal and gingivolabial sulcus? This is the gingiobuccal. Inside is the buccal and the outside is the labial. But what is the lateral gutter? Lateral gutter is basically when you elevate the tongue below the tongue, both the side is the gutter. Okay, so that is the lateral gutter. You have to mention anything, any lesions or anything, I mean swelling or whatever you have seen. If there is any, you have to mention that. If it is not, mention all the points. Okay, for the oral cavity palpations, 2 things you have to mention. One is if there is any lesion. If there is no lesion, also fine. If you find out any aphthous ulcer or anything, any ulcers, any swelling, you have to mention in the palpation. Okay. And the second thing is that you have to do a bidigital palpation of the submandibular, what is already discussed in the previous class. Okay. Now for the oropharynx area, that starts from the anterior pillar up to the base of the tongue, that is the oropharyngeal area. And you have to again do the inspection, which can be done by tongue depressions or just saying opening of mouth. And for the base of the tongue part, you have to do an indirect laryngoscopy, laryngeal mirror required. So this is the part where we both need the tongue depressions and the laryngeal mirror. Okay. And these are the things which will be inside the oropharynx. And in this part where you are writing the posterior pharyngeal wall, you have to mention the gag reflex. And when you are writing the soft palate part, you have to mention the palatal palsy part. This should not be missed. Okay? Very careful. Now the question is, we need to palpate oropharyngeal area. Do you need to palpate oropharyngeal area? Yes. So where do you want to palpate? Base of the tongue and tonsil. So these are the 2 areas we need to palpate, but base of the tongue when you see the lesion involving the base of the tongue. Not otherwise when you do the IL examination, you find out the lesion is in the base of the tongue, then only you can palpate the lesion. Okay? Otherwise not. And another one is the tonsillar area. If there is a lesion in the tonsil, you have to always palpate. Any other reasons why we palpate tonsil? Styloid. Okay? Styloid. Now come to the larynx and the neck part. There is again inspection of the framework of the larynx, neck of the larynx, neck around the larynx. Okay, so this is the inspection area where you have to see the framework is in midline or not, and also we have to find out any swelling around the neck is present or not. Okay, so what is playing of the thyroid cartilage, which can be palpated, can be understood by palpation? What is that? You have to mention this thing, is there present or not? Because if that is the widening of the larynx. Okay, so it's a widening of the larynx happens when the mass involving thyroid cartilage. Fine. So another palpatory pointing you should mention is the laryngeal crepitation, which is, you know everybody what is laryngeal crepitations. And if it is absent, then it is a Broca's sign positive. Fine. Now, again, I see in the presentation that in indirect laryngoscopic examination, there is a description of the lesion. Fine. but you also have to mention the things you can see in the indirect laryngoscopy, even though without the lesion. Okay, means what the structures you can see normally, what the lesions you are seeing and the extension of the lesion, and also try to draw a picture of the indirect laryngoscopy in the examination copy. Okay, make it practice. Okay, and neck swelling examination, palpation, I'm not going to discuss, because already thyroid examination class we have discussed these things. The size is very important, the location is very important, because for the 10M staging, okay, you have to understand that how much is in the greater dimension is also important. So that is the points where you have to take our note when you are examining the neck node. Okay. Now auscultation, what are the two things we have to see in the auscultation? In neck auscultation, what are the two things we need to take note of? Do you do ausculted neck? Yes, no? So, what are the two things? One is a hum, where we can see IJV, there is a venous hum. It is a continuous sound, okay? And one is a brute. That is because of the any stenosis or aneurysm is there, then we can find a brute is there, okay? So next is the one thing also I want to mention is that when you present the case, you have to mention also the ear and nose, all the points, not like that normal ear is normal and the nose is normal. You have to mention all the points, because that's also important when you're writing the long case, okay? The systemic examination has been done and it's discussed already, and then the summary and the provisional diagnosis. Fine. That's all for the clinical part, and little bit about investigation. Now, thing is that what is the first investigation you want to advise to this patient? When you has examined the patient, after that, what is the first investigation you want to do? That is the outpatient endoscopy. That is the first thing you want to do to see the lesions properly, and it can be flexible, it can be rigid, and then if you find out the lesions, plan for a biopsy. But the question is that, do you directly go to biopsy before going any radiological investigation? If you have seen the mass in the larynx, okay, then you directly plan the patient for a direct laryngoscopy and biopsy, or you will do before it something?
So first investigation.
Why is that?
Because sir, if we do biopsy first, then the architecture of that lesion will deranged, and that will give false positive result. Extent of the tumor will be
If
more.
you take a biopsy from the lesion, what will happen is that there will be
In the surrounding
edema.
inflammation.
Okay, and when doing the contrast for the lesions will look like a bigger one compared to the actual lesion. That's why we do the radiology first, then we do the biopsy. Clear is that? Now, for the biopsy, when you do the biopsy, it is very important to do a documentation, and we should documentation by both 0 degree or 90 or 70 degree endoscope. Why is that? We need to document we can document by 0 degree only, no? Why we are taking another 90 degree endoscope to take a picture? Why is that? To get a 3D imagination, a picture of the lesion. So for that we need a 2-dimensional view of that, 3-dimensional view for the lesion. That's why we needed both the endoscopes. And always take the multiple biopsy, never a single biopsy. Okay? And why we need to do it under magnification, although I can see the lesions very well with my naked eye. Why need a magnification? Why? Anyone? Ball, it's okay. It's to get, no, to identify the normal area. The normal area, to identify the normal area. You do not want to take biopsy from the normal mucosa. You have to preserve the mucosa. That's why it's the most important to get a magnification view when you take the biopsy. So also, we always do a palpations when do a laryngoscopy, when before taking the biopsy to extension of the lateral extension of the mass. That's also important. Now, my question is, stroboscopy is important. The stroboscopy or voice assessment is important before any planning of surgery or any planning of treatment, basically. If yes, then why? Why? No, not medical legal importance. If it is a very small lesions, you are not sure about the lesion, okay? In that case, the is only involving the mucosa, superficial layer of the mucosa, then also the stroboscopy will be not normal. The mucosal wave will be not there. And you can suspect there is there something and you can plan for the surgery. I mean biopsy, okay? And the second question is the soft tissue neck. Is there any importance of that? Do you do soft tissue neck in a CL Larynx patient? Yes or no? Yes, somebody says yes, I think. What are you? Yes? You can do it laterally, you can do it AP, whatever you will do, but this is the X-ray soft tissue neck of larynx. Do you do it before any planning of surgery or treatment of surgery? I mean treatment. Cervical spine. Oh, if you find something lesions in the cervical spine, that means this is a stage 4B. That's already in the cervical spine means that's a lesion is T4B. That means prevertebral fasciae involvement is T4B and you are going beyond that in the vertebra. Okay? So that is not required actually. That is not required. You can already get from the patient's conditions and the symptoms, you will get it out. That is a lost, this is a palliative patient basically. Okay? Anyway, FNAC, if there is a neck mass, obviously we should do an FNAC. And also you can do an USG, which is not written here, even if you want, but that is not mandatory, not necessary at all. What is important is that then you have to plan to CT scan and MRI. That is most important. CT scan and MRI both need contrast, okay? Without contrast, nothing is valuable here. And we have to do it CT scan and MRI. What is important to do an MRI? What is the advantage of doing an MRI, even though I get the lesion in the CT scan? One most important thing about MRI is this. Remember that any cartilage invasion by lesion best seen by MRI. Okay? If you think that is a thyroid is involved or not, you can get a clear picture with a CT scan. Always best think of MRI. MRI, if says there is no involvement of thyroid cartilage, that is more than sufficient that to understand that the lesion is not involving the cartilage. That is also important for staging. I will discuss it later on. Okay, so that is the main important. Another thing is that both the contrast, when you are giving contrast, there is also a that is already discussed, perilesion edema, which can be taken up by contrast, but it is more in the CT scan, less in the MRI. Okay, so MRI is better than in that situation also. Okay, another point is we don't normally miss. A patient who is very restless, cannot lie down for a long time, cannot be done MRI because that is a problem with an MRI. Okay, some patient the very respiratory difficulty is there, restless patient, so that time also we have to consider CT scan. The PET scan is basically to identify distance mates and also important to distinguish recurrence from the post-RT changes. That is very important. That is the point you have to remember. The post-RT changes and the recurrence can be distinguished by the PET scan. That is important. And recently the PET scan is more coming to the profile of the investigation for a CL Larynx. Okay? We always now include these things in our CL Larynx patients. Okay? Now these are the points which is not very important, but for the theoretical purpose, we can do a stain of the lesion and to identify the properly lesion where it is and then take a biopsy. That is the Lugol's iodine, the sort of things are there. And these are also not important. We are replacing these two investigations, video kymogram and digital imaging, to replace stroboscopy. They are more advanced things and we can get a better pictures of the lesion in a real view. This video kymogram is basically a graph, not a picture. Okay, it's a graph representations. And electromyogram can be also done. A myogram is basically for the identification of the paresis with a arytenoid fixation. Okay, and the narrowband imaging is also can be done for identifying the proper lesions and to take a biopsy. One thing I want to ask you is this is a question can be asked is that is the screening is important for CL Larynx? Screening the patients. High risk patients are two high risk patients, one elderly male patients and low socio-economic conditions patients. These are the high risk patients mainly. So we have a protocol to thinking of screening those patients. Why is important to do a screening? Because because of the vague symptoms developed by supraglottic and subglottic lesions. They are very vague symptoms initially. We missed out those things, and they present us within a very advanced stages. That's why. So we need a screening, but it's very difficult to do in a CA Larynx patients because of availability of the specialist and the equipments. Okay. Okay. Just a brief between the staging, because already we discussed the subunits of the supraglottic part, glottic part, and subglottic part. So the staging is mainly initiated by the European Society, but ultimately they were taken over by the AJCC. You know all the names, I think. You need to know the full name of those two words. Okay? AGCC, what is the full form? Anyone? Okay, fine. So we are normally following those things. These are the aims of staging. I don't want to discuss these things. These are the subunits already discussed. There is no subunit for subglottic. Remember that. Okay, now first come to the supraglottic. It is, I don't want to discuss things, but what we want to discuss is that T3. There is a no mobility. Vocal cord is no mobile. So initially without no mobility, if it is within the larynx also, it is T3. Okay? And the subunits, if it is more than one subunit, there are 5 subunits I told you before. This is the 5 subunits. If it is involving more than one, it's a 2E2, even though all the cords are mobile. Okay? Get it my point? So if only one subunit is involved with a mobility, that is a T1, more than one with a mobility, then it is a T2. T3 is basically within the larynx, but the mobility should be gone. Okay? But what is important here to remember is that the last 3 points, this is what you should take care of. If the larynx is within the larynx and also extending beyond the larynx, means cricoid, post-cricoid, pre-epiglottic, or the inner cortex only. That's important. That's why the MRI comes in the play. If you do an MRI, you can differentiate between the T3 and T4. It only involving the inner cortex, then it is T3. If it is involving the outer cortex, then it is a T4A. That's the MRI is doing the trick here. Okay? And all the other structures involvement are T4A. What you have to remember is that if you can't remember the thing, starts with the below. I mean, remember the T4B first. These are the 3 structures when involved, it's T4B. Prevertebra, mediastinum, and carotid. It's there for everyone. I mean, supraglottic, glottic, and subglottic. Everywhere T4B is the same. Remember that thing. Okay? So, and also remember this 6 structures. This also similar for glottic and subglottic also. Okay, I will show you. So these are the things, and for the glottic only there are 3 subunits basically. That is the vocal cord, anterior commissure, and posterior commissure. So if the one cord is involved with the mobility is T1A, we divided the 1 into A, B because of the 2 cords. 1 cord, 1A, 2 cord, 1B. Okay, and if it is involving outside the glottic, that means it's a transglottic now. So it's a T2. Okay? And same thing for the 3, it's within the larynx, but again the thing is that mobility should be gone. So mobility should be gone means in a glottic also T3. And the T4A and T4B are the same almost. And so why not mention, just remember this thing, T and T4A, T4B is almost same. Now the subglottic, there is no subunits. Subglottic, if there is a vocal cord mobility is present, then it's always T1. And T2 is when the one or both cord involvement. That means it goes up. So it's a T2. And it may or may not be with or without mobility. Okay? So it can be fixed, it cannot be fixed. Okay? So again, 3 is basically the same, limited to the larynx without any mobility. And the rest of the things are same. Now nodes, I think you know these things. I am not going to discuss these things. And what is important that it is basically similar to all head and neck cancers. What is important to do in staging is that we need to staging because there are almost 24 probabilities. If we get T, N and M, then there are 24 probabilities. And to simplify that, we made this staging. All the head and neck cancers are same except the thyroid discussed, and the nasopharyngeal cancer. Okay? And last one, the slide is for you. Just you have to remember these 3 subunits for hypopharyngeal carcinomas. Okay? If it is a hypopharyngeal carcinoma, these are the subunits, and there is a confusing part. Can you tell me what is the difference between the post-cricoid and posterior pharyngeal wall? That is already written there, but they actually come to the same area. Okay, what is the difference? This is anterior, this is the posterior. That is the difference. Post-cricoid is anterior and the posterior pharyngeal wall is the posterior part. But their levels are the almost same, no? But posterior pharyngeal is much bigger level, but the post-cricoid is smaller level, but they're lengthwise different, but the anterior and posterior only. Okay? And this is the T1, T2, T4. Okay? And I'm not going details. You just remember these things, okay? Excess soft tissue neck, we don't do now. It is not. Check for the basically post-cricoid area. Is anything there in the masses lesion is there, any edema is there, is for retropharyngeal abscess is there. So that's what we are looking at. But nowadays we have a CT scan MRI, so we don't need to do an X-ray now.
I would just like to add 2 things. That is NBI, narrowband imaging, something that has come up in a big way. Because of the extreme high cost of the instrument, we don't have that in most of our institutes. But for exams, I think you have to know a little bit about narrowband imaging, and it definitely is a very good tool to assess early carcinoma of the larynx. And there are different predictive issues, you all get in the net, different classifications. So I would suggest narrowband imaging is done in most of the advanced centers to identify the precancerous lesions that you should go through as a short note at least for your exams. And number 2 is regarding the stroboscopy part again. In early cancers, T1 and T2, where you have got maybe only radiotherapy will suffice, or you do some degree of cold steel or laser, T1, T2, where you have got some mobility of the vocal folds. Stroboscopy helps both in 2 ways. Number 1, if you do not have any mucosal wave in the stroboscope, you know that the lesion has gone into the rinky space. So you plan your surgery according to that. I mean, the different types of chordectomies in early cancer. So again, the different levels of types of chordectomies, the European classification, again you have to go through that, because not all the cancers are T3, T4. We are dealing from T1 to T4. So one is by stroboscopy, you know whether it has involved the rinky space, and number 2, as a follow-up, or it helps us to know whether there is any recurrence. Maybe a T1 or T2 has undergone radiotherapy. In subsequent follow-ups, you do a stroboscopy and you suddenly say there is some loss of mucosal wave. So you know that probably there is some recurrence. So definitely stroboscopy helps in as a prognostic tool in early carcinoma larynx.
Thank you, Chamutkar. So it's a very important thing. We are progressing from IL to FOL to stroboscopy. And you all know stroboscopy, recent advance was short note, MS exam, different applications of stroboscopy, voice analysis, all this. So you have to know it and importance of it. But don't forget the IL examination, at least for your MS exam. FOL has become the part of our, say it's not investigation now, it has came in the chapter of clinical examination. You can say it's clinical examination or investigations, anywhere. But how to improve your result of IL examination? যদি একটু বয়স্ক এক্সামিনার হয় সে কিন্তু জিজ্ঞেস করবে আইএল করে তুমি দেখতে পেলে না, ফরগেট দ্য এফওএল, হাউ ক্যান ইউ হ্যাভ আ বেটার ভিউ উইথ আইএল এক্সামিনেশন? এটা ঢোকালে ঢুকিয়ে ভালো দেখতে পেলে না, তুমি বলো। You don't have anything, you have to see the growth with your IL exam. এই মাইকটা কোথায় দাও, আরেকটা মাইক দাও, এই তো মাইক আছে একটা, বলো তুমি বলো আইএল এক্সামিনেশনে কীভাবে, কাকে বলেছিলাম তোমাকে, বলো। আগে তো এক্সপ্লেন করলে, ওটা তো বেসিক থিং, তুমি করলে, এবার দেখতে পাচ্ছ না, কী করে আর টু বেটার, মানে হাউ টু ইম্প্রুভ ইউর রেজাল্ট? অ্যাঙ্গেল চেঞ্জ, ওয়ান ইজ দ্য ইউ ক্যান চেঞ্জ দ্য অ্যাঙ্গেল অফ দ্য মিরর, you can make it 50 degree, you can make it 90 degree, কিন্তু আবার বেশি করে দিও না, ফরেন বডি হয়ে যাবে ভেঙে গিয়ে। ওয়ান থিং। অ্যানাদার ইজ দ্য ডিফগিং তো আগে হয়ে গেছে। উইদাউট ডিফগিং ইউ ক্যানট সি এনিথিং। হাইট চেঞ্জ height of the মানে tool, not the examiner of the patient, height of the tool of the patient and examiner, একটু উঁচু হয়ে বসলে নিচু হয়ে বসলে। and another thing, স্প্রে আমরা যেমন দেখছি তবে 10% লক স্প্রে দিয়ে যখন ছিল না তখন কি করে দেখতো লোকে, আজ থেকে ধরো 10-15 বছর আগে লোকে তো দেখতো, আইএল করেই তো সব কিছু হতো। So these are the way you can improve your result of IL examination. So কিছু হলো laryngeal crepitus হয়ে গেছে, clinical examination describe, FOL, fiber optic, imaging হয়ে গেছে, CT MRI no doubt about it, that is the main thing. CT MRI is the main modality already described by Dr. Shantanu. So these are the epiglottis, vallicula, this is the pre-epiglottic space, it's very important. This is the pyriform fossa, pre-epiglottic pyriform fossa. Vocal cord, how can you say it's vocal cord in a CT scan? How can you identify vocal cord in CT scan? তুমি বলো, সিরিয়াল কার্ডস আর দেয়ার, ভোকাল কর্ড কীভাবে আইডেন্টিফাই করবে? মুভমেন্ট তো সিটি স্ক্যানে দেখতে পাচ্ছ না। পিয়ার শেপেড, পুরোটাই তো পিয়ার শেপেড। এটা ইজ ইট ভোকাল কর্ড? এটা যেটা দেখাচ্ছে ইজ ইট ভোকাল কর্ড? থাইরয়েড কার্টিলেজ তো অনেকটা দূর পর্যন্ত আছে। অ্যারিটিনয়েড আছে, অ্যারিটিনয়েড লং স্ট্রাকচার। আইডেন্টিফিকেশন অফ ভোকাল কর্ড ইজ আ ভেরি ট্রিকি জব। একটা কার্ড দিয়ে বলবে হোয়ার শো দ্য ভোকাল কর্ডস। So vocal cords, when you can see in a single axial cut, all the three cartilages, arytenoid, cricoid and thyroid, তিনটে কার্টিলেজ যখন একটা সিঙ্গেল কাটে দেখা যায়, that soft tissue is the vocal cord. You see the lower one, here is the arytenoid, here is the cricoid and this is the thyroid. In a single axial cut, when you can see all the three cartilages, that soft tissue is the vocal cord. So imaging of the say larynx already described what to see, what are the subsite, or what is the extension, tumor, volume and all these things. So TNM staging described, what is described is the, in most of the books or what you follow is the 7th edition. But recent is the 8th edition, it's 8th edition from 2018 January, it is 8th edition. We are going through the 8th edition. So the changes কিছু আছে কিন্তু দেখবে 7th এর সাথে 8th এর, সেটা দেখো। UICC মানে আকাশ, হোয়াট ইজ UICC? AJCC তো একজন বললো, আমেরিকান জয়েন্ট, অ্যান্ড UICC এগুলো জাস্ট ভেরি কমন টার্ম, এগুলো জানতে হবে। ইউনিয়ন অফ ইন্টারন্যাশনাল ক্যান্সার, ইন্টারন্যাশনাল কমিটি অন ক্যান্সার, ইউনিয়ন অফ ইন্টারন্যাশনাল কমিটি অন ক্যান্সার, UICC, এটাকে এখন একভাবেই ধরা হয়। So 7th and 8th edition we are running, and 9th edition will come in 2025. The nasopharyngeal, now 9th edition will come. CTNM, CT scan, is it required or not for CTNM? Not required. So CT scan required for what is PTNM? Pathology. CT scan not mandatory but required. CT scan not mandatory. Anything before operation, biopsy, say FOL, say CT scan, MRI, all these are required, but CT scan is not mandatory but required. And PTNM, that is CTNM is before operation. So you are doing CT scan before operation, you are doing MRI before operation. So CTNM is before operation. Whatever you do, all are required. And PTNM after operation. And you will be asked regarding limitation of the TNM staging. আমি এখানে পড়াচ্ছি না, জাস্ট একটা প্যারাগ্রাফ আছে, দুটো পেজ আছে, পড়ে নেবে স্টিল। হোয়াট আর দ্য লিমিটেশনস অফ TNM staging? TNM staging আর T3 T4 এগুলো তো জাস্ট একটা সব ডেসক্রাইব করা হয়ে গেছে। TNM classification, 8th edition there is some change in the nodal thing. Their importance is given on extra nodal extension. জাস্ট এটার মনে রাখবে এক্সট্রা নোডাল এক্সটেনশন যখনই থাকছে ইট ইজ আপগ্রেডেড, স্টেজ 2টা 3 হবে এরকম একটা আপগ্রেডেশন আছে। সো জাস্ট রিমেম্বার দ্য চেঞ্জ, ইটস নট দ্য N1, N2, N3. হ্যাঁ, 8th edition there is definite changes in extranodal extension is given importance and upgradation, without extranodal extension and with extranodal extension. Any lymph node with extranodal extension is always N3, it is always N3. Management. So we have taken the history, biopsy, staging, all are done. Our case was stage 3, intralaryngeal stage 3, and there is stridor, that is you can say functional larynx, or it started to be a dysfunctional, non-functional larynx. Still it is functional. So there is a paradigm shift in the management of carcinoma larynx. 20th century মানে 1999-98 এসব দিকে main modality was the surgery. Total laryngectomy was a very frequent operation, and it's a excellent operation prognostically. You can have a total cure of the cancer with the total laryngectomy. Stage 1, 2, 3 disease, do total laryngectomy and patient is cured of the disease. But problem is the voice. So there is paradigm shift towards the conservation surgery, total open laryngectomy or endolaryngeal procedure, and move towards the more organ preservation by chemoradiotherapy. Management options, these are the management options. So radiotherapy and chemotherapy is very important nowadays. That part will be described by Dr. Devanshu Ghosh. So if possible, if larynx is functioning, we are going for the conservation voice preservative surgery, voice preservative management.
Radiation therapy and or chemotherapy non-surgical management এর মধ্যে আসে। I have only 5 slides, আমার মাত্র 5টা স্লাইড আছে। কেন দিস এরিয়া ইজ এ ডাইজি এরিয়া। ডাইজি এরিয়া কেন বললাম? কারণ উই টেক বায়োপসি, আমার ওপিডিতে এরকম যদি পেশেন্ট আসে, বায়োপসি করতে স্যার অ্যালাউ করেন, বা স্যার কোনো একটা অপারেশন করলেন টোটাল ল্যারিঙ্গেক্টমি, যেটা সার্জিক্যাল ট্রিটমেন্ট। সো উই টেক দ্যাট, উই আন্ডারটেক দ্যাট সার্জিক্যাল প্রসিডিওর, অনেক দু একটা আমরা দেখেওছি হয়তো ল্যারিঙ্গেক্টমি, ঠিক আছে। বাট কিছু পেশেন্ট, বাট ইন সাম অফ দ্য পেশেন্ট মাই টিচার রেকমেন্ড কি প্লিজ সেন্ড দ্য পেশেন্ট টু দ্য রেডিয়েশন ডিপার্টমেন্ট, বা দোজ অফ দ্য ইনস্টিটিউট উইচ আর হ্যাভিং লাইক আওয়ার ডেডিকেটেড হেড অ্যান্ড নেক টিউমার বোর্ড, মাল্টিডিসিপ্লিনারি, যেখানে রেডিয়েশন অঙ্কোলজিস্ট থাকে, মেডিকেল অঙ্কোলজিস্ট থাকে, ওকে, সেই সব প্যাথোলজিস্ট থাকে, তারা দে এন্ডোর্স দ্যাট ট্রিটমেন্ট বাই টেকিং ওপিনিয়ন ফ্রম অল দ্য সারাউন্ডিং ডিসিপ্লিন, কি এটার এই স্টেজে এই সাবসাইট, এই অর্গান, এই ট্রিটমেন্ট, ওকে, দ্যাট ইজ বেসড অন দ্য স্ট্যান্ডার্ড গাইডলাইন। নাও যেহেতু অ্যাজ বিকজ অফ দ্যাট সর্ট অফ পেশেন্ট উই ডু নট সি যে after sending the patient to the radiation oncology department, what is going to happen there. That's why, as we don't see that treatment in front of our eyes, that area remains to be very dicey. So, to sum up, whenever I will conclude the 5 slides, at the end you will understand more or less there is a gross similarity between the treatment of the laryngeal carcinoma as well as hypopharyngeal carcinoma. Okay. Now coming to the laryngeal carcinoma. Carcinoma, suppose T1 and T2 glottic. Now we are coming to the glottic subsite, carcinoma of the glottic. So if it is T1 or T2, by the time TNM, from the TNM you know what is T1 and what is T2. Okay. So early যদি laryngeal carcinoma হয়, both in you see T1 N0 or T2 N0, treatment is 2, and both have similar cure rate. What are those two treatment? একটা হচ্ছে simple radiotherapy, that is a conventional radiotherapy, external beam radiation therapy, or transolar laryngeal resection by using CO2 laser. Okay, এই স্টেজে both the treatment have a similar cure rate. And what is the dose of radiation? That is very important. That is often asked in your practical. What is the dose of radiation given in case of T1 glottic carcinoma, T1 laryngeal carcinoma? What will be the dose? Dose will be 60 gray at 2 gray per fraction and 5 fraction a week. Okay, and that will span a duration of total 6 to 7 weeks. That you have to remember, and that is the least dose. You can have a higher dose than that, but that is the least dose you have to remember. Now, what are the types of radiation in this T1 and T2? একটা হচ্ছে concurrent radiation, concurrent radiotherapy for small T1 carcinoma. It is known as small portal radiation therapy. Why it is small portal? Because the whole radiation beam is focused to that area of growth. So other areas is less exposed to the radiation effects. Okay, that's why it is called the small portal. Another is that radical radiotherapy for T2 or higher than T2 stage, T stage. It is a high, but what is the problem of this? There are some problem like that. It has higher incidence of laryngeal and pharyngeal dysfunction. What is the laryngeal dysfunction? কি হতে পারে? Laryngeal dysfunction কি হতে পারে? Hoarseness of voice হতে পারে। যে পেশেন্টের hoarseness ছিল না, as a result of radiation, because radiation cause potential chondrolytic or chondrotic effect. Okay, chondritis করে। সেই কারণে hoarseness হতে পারে after radiation therapy. And what is the pharyngeal dysfunction কি হতে পারে? Patient may have dysphagia or difficulty in swallowing. So this can happen from that as a side effect of the radical radiotherapy. Okay, and another thing this radical radiotherapy does, suppose that we have given radiation stage specific, after some time there are some recurrence. Okay, but usually after radiation therapy there is obviously some edema and that persists for some time, but that edema may mask the recurrence if at all there is a recurrence. So edema জন্য আমরা বুঝতেই পারবো what is actual recurrence, what is edema due to radiotherapy. Got it? Another form of radiation therapy is a concurrent chemoradiation. কোথায় দেবো? What are the indication? Tumor is very bulky or there is impaired cord mobility as to go to the stage T2 যেখানে cord mobility থাকে, impaired cord mobility as per the TNM. In that case we will give the concurrent chemoradiation, meaning thereby you have to give a chemotherapeutic agent along with the radiation. What is the most commonly agent given? Cisplatin. Why it is given? Why cisplatin is given? Because it is one of the radiosensitizer. It increases the effect of radiation. Okay. Due to molecular effect, radiation effect বাড়ায় বলে আমরা as a radiosensitizer we add on the cisplatin. But it has a potential side effect. If the patient has a hepatic impairment or your pulmonary impairment or particularly the kidney impairment, we cannot give the cisplatin. What is the dose? Dose is weekly dose of 30 milligram per meter square body surface area. That is the dose of cisplatin within these 6 to 7 weeks of this radiation. That has to be added. Meaning thereby it is a concurrent CT plus RT, concurrent chemoradiation. Okay. There are 3 modes of radiation. Now there are some factors that decide the treatment due to radiation. What are those factors? Number one factor is the T stage. T stage I have already spoken. Suppose there is a T1. What is the treatment? Transoral laryngeal resection using CO2 laser or open surgery, open partial laryngectomy surgeries, not the total laryngectomy, or radiotherapy. All have equal effect. You see it is written equal. For that T1 stage, mind that. But for the T stage, T2 stage where there is impaired cord mobility, surgical options that is transoral laryngeal resection or open partial resection of the larynx scores more than the radical radiotherapy. So, this is the how treatment is compartmentalized, the treatment is decided. Now, advanced T2 stage, chemotherapy obviously has a higher score than radiation alone, chemoradiation therapy, that is the chemoradiation therapy. Okay, and if surgical treatment is not the choice, provided surgical treatment that is the open partial laryngeal resection, that is a subset of surgery known as open partial laryngeal resection. There are 2 classifications. You have to read sometimes of that. There is vertical laryngectomy procedures and horizontal laryngectomy procedures. এগুলো সব আগে আসে before the total laryngectomy. There is something less total laryngectomy procedures. So in that case, it is not the surgery. Then you have to add on in case of advanced T2 chemoradiation therapy. Okay. Now second factor is that either anterior commissure is involved or not. That is a dangerous area. By the time you know from the previous lecture, because in that case, what change we have to made in the radiation? We cannot give external beam radiation. Rather, we have to give, if AC is involved, mega voltage radiation therapy. Okay, or intensity modulated radiation therapy, IMRT. What is the advantage? We take the CT scan, we put the patient in the gantry, based on the exact area of the growth. Okay, that gantry rotates around the patient, the radiation dose is focused particular area, not in the surrounding area, to have minimum collateral damage. That is the beauty of the IMRT, intensity modulated radiation therapy. Second, next comes the tumor histology. Another factor. Why it is important? Because suppose verrucous carcinoma, you have heard the term. Verrucous carcinoma is very much radio resistant. In that case, radiation has a very minimum role. So, histology is very important. And fourth factor is the age and comorbidities. Lower the age. Suppose patient is a lower age group. What will happen if we give the radiation? Ki hote pare? Lower age cancer hoyeche. If the cancer is affecting a lower age, what may happen? What side effect may happen or complication may happen? Number one is second malignancy chance is much more. Okay, particularly which malignancy occur very commonly after radiation exposure? Thyroid malignancy. So in low age group, we cannot give that radiation therapy. In that case, the treatment here is the surgery, you see. Surgery is preferable in lower age group than the radiation because of this reason. Okay. Also, not only thyroid malignancy, other malignancy, second malignancy, maybe hematologic malignancy in other malignancy in the body can happen after in a long-term sequelae of radiation therapy. Secondly, patient's voice demand. Patient is asking, doctor, I must have a good voice after the treatment. In that case, radiation usually preserves the voice. Okay. So, in that case, radiation is recommended compared to the other treatment, two treatment I have told. And socioeconomic constant and access to the necessary expertise. Suppose patient is residing in a distant place, cannot come for a regular follow-up. So, this is another factor that will determine that choice of treatment. Now, coming to the supraglottic, same T1 and T2 supraglottic carcinoma. What is the treatment? Radiation therapy alone is an option for T1, where the local control kotota achieve kore 75 to 100% almost. That means T1 and T2 the radiation results are excellent. Okay. And small T2 lesion, mind that it is small T2 lesion, not that previous big T2 lesion where we hope to have that radical radiotherapy, small T2 lesion, where the local control rate can be achieved up to 60 to 83%. Okay. Now, there is a tendency in this sort of case to gradual shift towards the surgery. What is the surgery? Partial laryngectomy procedure. Do you know any partial laryngectomy operation that is taken in case of supraglottic larynx? It is supracricoid partial laryngectomy with cricohyoidoepiglottopexy. That is the operation, partial laryngectomy procedure that is undertaken in case of supraglottic growth. On the contrary, in a glottic growth, that is the SCPL, supracricoid partial laryngectomy, but without cricohyoidoepiglottopexy. Remember that. Okay. Now, another treatment for the supraglottic, same T1, T2 stage is the chemoradiation, where same, you see, it is the bulky T2 lesion where transoral laryngeal resection by the CO2 laser is not feasible. Okay, coming to the subglottic, we have covered the glottic, we have covered the supraglottic. Now, coming to the same stage T1, T2 subglottic, where the external beam radiation, mind that it is external beam radiation therapy is the mainstay of treatment still now. And where the combined chemoradiation is indicated in case of subglottic tumor when there is a extensive lymph nodal metastasis, extensive locoregional spread in the lymph node. Okay, these two conditions. Now, T3, cancer of the larynx, that is also known as intermediate stage. Early stage means T1, T2, intermediate stage means T3, advanced stage means T4. T4 er abar T4A ache, T4B ache, as per TNM. What is the treatment? Now, what the paradigm shift I was speaking of, that is the paradigm shift in treatment recently as per RTOG 911 guideline and other NCCN guideline, that is coming up in a big way in this way, area of T3. Okay. Previously, we used to do total laryngectomy in all the cases of T3, particularly glottic carcinoma or transglottic. In our case is a T3, okay, but the treatment here is very critical. Probably this is the treatment that has to be undertaken in our case, that is T3 we have already staged by their case history. Now, there are two treatment options. What are the two treatment options? Concurrent chemoradiation or the bioradiation. Bioradiation can come as a short note. That is a big term nowadays. What is the concurrent chemoradiation? What is the dose? That is a 66 to 70 gray radiation therapy. As it is concurrent chemoradiation, we have to add cisplatin over the total duration of 6 to 7 weeks. So, what is we can achieve? There is the overall local control including larynx preservation rate in this concurrent chemoradiation therapy is 75 to 80%. That you have to remember. Okay. And suppose patient have a renal impairment, cardiac impairment, or hepatic impairment, can we give that cisplatin? I have said already no, because it is very, very toxic drug, more so to the kidney part. Okay, in that case, concurrent means you are giving radiation along with you are adding some chemotherapeutic agent. Cisplatin is a chemotherapeutic agent, you are adding with radiation. As a result of that adding, you are increasing the side effects also. Radiation has got some side effect, mucosal side effects, dermatological side effect. Along with that, you are adding some systemic side effect as a result of chemotherapy agent. Now, suppose elderly patient is one elderly patient has come with a poor renal function. Can you give the cisplatin there? No. What is the alternate option there? It is the cetuximab, that is the monoclonal antibody. It acts by blocking what? Epidermal growth factor receptor, EGFR blocker. Okay, that can be added as a alternative to cisplatin plus with radiation. That is the bioradiation. That has a very good effect, but only downside is the cost. That monoclonal antibodies are very, very costly drug. Patient often cannot complete due to cost the whole treatment schedule. Okay. And another is the induction chemotherapy. There is also neoadjuvant chemotherapy, followed by, there is option 2, followed by concomitant chemoradiation or combination chemotherapy plus radiation therapy in good responders. Suppose, and surgery in poor responders to the ICT trial. So what is that trial? We will undertake 2 cycles of induction chemotherapy with either 2 drug regime, namely cisplatin or 5-fluorouracil, or 3 drug regime, 1 taxane, 1 platinum group of compound, and 1 5-fluorouracil. We will observe the effect on those, response on those drugs. 2 cycle we will give like that. Suppose somebody will respond in the T3 stage, somebody won't respond. Those who will be responder will continue with the combined concomitant chemoradiation, CRT, that I have already told. And those who will not respond to that will directly post that patient to the surgical arm. Okay. And now ICT, that induction chemotherapy, also known as neoadjuvant chemotherapy, because it is undertaken or given before any surgical procedure or surgical treatment, is preferred over concomitant chemoradiation at the outset. At the outset means very beginning. We won't go to see the response after 2 cycles. But from the beginning, there are 2 indications only when we will follow this treatment. Only 2 situations are there. What are those 2 situations? In those T3 stage disease where voice conserving surgery is feasible, but non-surgical organ preservation is desirable. Suppose, sir has told in examination, you have doing the indirect laryngoscopy. You are seeing that your somebody is telling that hemilarynx is fixed. Somebody is telling, sir, vocal cord is fixed, but arytenoid is not fixed. There is a flicker of movement of arytenoid, I can see, sir. Are these 2 terms synonymous? No, hemilarynx fixed means whole the larynx in the half, including the arytenoid, will be fixed. So, in such a case where vocal cord is fixed, but you can still observe the flicker of movement of arytenoid. That means arytenoid cartilage of that side is still mobile. Of that transglottic tumor, it is one of the indication of ICT over CCRT at the outset. Okay. And another indication is the bulky T3 disease with resectable node, very high lymph node, size as Sir has told in the TNM, T2A, that is 3 centimeter, or N3, that is, if response well to ICT but nodal disease does not, then neck dissection done before CCRT, combination chemotherapy, because CCRT cannot take care of the bulky neck node. For that, you have to take a separate treatment. Okay. What is the treatment? Neck dissection. Then post the patient to the CCRT. And the last thing is the T4 cancer larynx, both T4A and T4B. By the time you know what are the 3 structures to be fulfilled to get the definition of T4B, chemoradiation is unlikely to succeed. Why? Because maximum cases we get the cartilage is eroded. In erosion of the cartilage, that this radiation and chemoradiation cannot act properly. Okay, you have to undertake surgery. Now coming to the hypopharyngeal cancer. Again, you see quite similarity in here compared to the larynx. In early stage of hypopharyngeal cancer, radiation therapy and surgery, I have written yield a similar result. Early means T1, T2. Okay. For advanced disease, radical surgery followed by radiotherapy. Nowadays, upfront CCRT is often used. Upfront combination chemotherapy and radiation therapy in advanced hypopharyngeal cancers. Now, early hypopharyngeal cancer, as in case of T1 and T2 stage, although radiation therapy alone is effective, as I have already told, CCRT has become a treatment of choice for those able to tolerate this treatment. Because I have said, because you are combining radiation with the chemotherapy, maximum patient, frail patient, having comorbidities, cannot tolerate this. So who can tolerate this? In that case, this is the treatment of choice. Particularly palpable, those with presenting to you with a palpable neck node of having 3 centimeter diameter neck node. That means locoregional metastasis has already happened. Okay. In that case, we can go for that CCRT. And coming to the N0 neck, if surgery is the primary modality, same treatment for the, where the primary modality is one, in T1 and T2 early disease, then selective neck dissection and radiation is the treatment of choice. Suppose we are treating with radiation for the N0 neck. N0, what is N0? In that case, the same treatment modality you have to apply for the neck also. Okay, in surgery, selective neck dissection, if it is radiotherapy for the primary, for the neck also radiation. Okay. Now coming to the advanced hypopharyngeal carcinoma of T stage 3 or 4. What is the treatment? Radiation alone is ineffective in this case. Cannot work. But here again, we have to go for the neoadjuvant or induction chemotherapy with the same 3-drug regimen is said to have a better effect than 2-drug regime nowadays. And we have to give 2 to 3 cycles where each cycle spans over a period of 4 to 5 days. Okay. Now, one arm may be complete responders. We'll directly put that patient to radical radiotherapy. Nowadays, we have to use the sequential radiotherapy, concomitant radiotherapy, instead of that radical radiotherapy. And the another arm is the poor responder, just like the larynx. T3 of larynx, same. Where you have to give the poor response, directly you place the patient for the radical surgery. Like laryngopharyngectomy, total laryngopharyngectomy, or partial laryngopharyngectomy, okay, or total laryngopharyngectomy with gullet reconstruction kind of surgery. These are all big surgeries, very radical surgery. Okay, and there are some 2 situations where I am coming to that, T3 lateralized pyriform sinus carcinoma where near total laryngectomy is feasible, and another condition is that T3 pyriform sinus carcinoma with bulky resectable neck node. Okay, in these 2 situations, directly we will go to this treatment. Because it has been seen in these 2 situations, the response to this treatment is better. ICT followed by this. Now, another treatment for the advanced hypopharyngeal carcinoma is the concurrent chemotherapy and radiotherapy. Single agent cisplatin here is given 3 weeks. Dose is same, mind that. 100 milligram per meter square. If you are giving that weekly 30 milligram per meter square, this is followed in India and this is in abroad. This dose of cisplatin. And this is for the total duration of radiation, 6 to 7 weeks. And another is the biotherapy, or you can change the fractionation to have the more effect of the radiation. What are the change? You may have the alternate fractionated radiotherapy or accelerated fractionated radiotherapy. These are all technical terms in view of that radiation oncology. You did not know in detail of this. Effect ज़्यादा होता है, effect is more. Okay. Now coming to the far advanced, that is T4A hypopharyngeal carcinoma. Always the treatment is here surgery followed by radiation, and this is nowadays also followed in some intermediate stage hypopharyngeal carcinoma. Means I am not written in classification, I am written intermediate. Okay. But here also intermediate also there in T3. Here also, in some of the intermediate carcinoma, this is the treatment, surgery for radiotherapy. Now coming to the neck node, along with hypopharyngeal carcinoma. N1 neck disease, low volume neck disease, if it is more than 2 centimeter, or you are finding no necrosis or imaging in the neck node. So in the CT scan, it is not your duty to see the primary lesion, you have to see the neck node. There are some features, radiological features, what are the malignant lymph node, how does it look like, and benign lymph node, how does it look like. Okay. So it is not the purview of the discussion today. So in that case, you are not getting anything such that. Same way as N0 neck, that means surgery or radiation therapy. That I have already told there. Okay, surgery or radiation therapy you have to take in case of low volume neck disease. And if it is a high volume neck disease like advanced neck disease, N2 or 3, Usually neck dissection, to resect those neck nodes, you have to undertake separately, either before, most of the cases, after the treatment for the primary. Okay. So that's all. Any question? Because it is difficult, but you have to go through once. So you can write a short note or any long question coming on that non-surgical management. Okay.
So you have to know little bit of that thing, that chemoradiotherapy, because it's the mainstay of treatment nowadays. হ্যাঁ, যদিও সকাল থেকে শুনে শুনে কারোর মাথা আর খুব ভালো কাজ করছে না, আমি জানি না কারোর ব্রেনে আর কিছু নিচ্ছে কি না। এনিওয়ে, সো ওটা চেঞ্জ করার সময় বলছি, হোয়াট ইজ 4A, 4B, হোয়াট ইজ 4C? যার কাছে আছে মাইক, হোয়াট ইজ 4C? বলো বলো। স্টেজ 4C. Stage 4C is there. We are running through the 8th edition. Stage 4C is here. 4C, when there is distant mates. So 4A, 4B, 4B সবার একই আছে, তিনটে criteria. 4C is there when there is distant mates. So it is already described. So treatment already described. Stage 1 or 2B, আমি এগুলোতে যাচ্ছি না। Surgical option, endolaryngeal surgery, a little bit described, total laryngectomy and open partial laryngectomy. Options are in partial chordectomy, vertical and horizontal partial laryngectomy. Open partial is not preferred nowadays, অতএব এটা নিয়ে তোমাকে কেউ খুব বেশি জিজ্ঞেস করবে না। Generally the cancer surgery generally accepted margin is 5 cm, at least 5 millimeter. Preferably 2 centimeter, at least 5 millimeter. But here 1 millimeter margin is accepted in that thing, endolaryngeal surgery. Open partial laryngectomy এখন describe করার সময় নেই। Wide field total laryngectomy, যেহেতু এটা একটা classical thing in CNT, wide field total laryngectomy, অতএব তোমাদের একটু জেনে রাখতে হবে। Anyone have seen the total laryngectomy in your PGT sheet? No one? ও দেখেছে তো, অনেকেই দেখেছে টোটাল। যারা দেখেছে তারা জানে যে হোয়াট আর দ্য স্টেপস অফ টোটাল ল্যারিঞ্জেক্টমি। মেনি স্টেপস আর দেয়ার। দিস আর দ্য জেনারেল সার্জন থিওডর বিলরথ, যে ফার্স্ট করেছিলেন। সো হোয়াট ইজ দ্য ইন্ডিকেশনস? এখন তো টোটাল ল্যারিঞ্জেক্টমি করা যায় না। ইন সিঙ্গেল লাইন ইউ ক্যান সে দ্য ইন্ডিকেশন, দ্যাট ইজ নন ফাংশনাল ল্যারিংস। ফরগেট T1, T2, T3, T4, T10. It's not important. Important is the non-functional larynx, that is the basic function, voice and respiration. যদি না থাকে তাহলে তো শুধু টিউমার বার্ডেন রেখে কোনো লাভ নেই। সো নন ফাংশনাল ল্যারিংস যে কোনো স্টেজেই, দ্যাট ইজ দ্য ইন্ডিকেশন অফ টোটাল ল্যারিঞ্জেক্টমি, অ্যান্ড অফকোর্স দ্য প্রিভিয়াস ট্রিটমেন্ট ফেইলিওর। দিস টু আর দ্য অনলি ইন্ডিকেশনস অফ টোটাল ল্যারিঞ্জেক্টমি। Wide field total laryngectomy, preparation, communications and all these that come to the directly to the skin incision. Just to describe the steps only. This is the classical Gluck-Sorensen incision, but horizontal incision is also preferred. Two types of incisions are there, horizontal and Gluck-Sorensen. This is easier one, and it is preferred in tracheostomy patient, so that you can take the stoma here. So flap elevation, you all know it's the subplatysmal plane. All the neck flaps, je kono surgery always in the subplatysmal level. Elevate up to the suprahyoid and suprasternal notch, totally exposed neck. Mobilization of the larynx, তাই তো larynx attached আছে। Total larynx is a very simple surgery. Only thing is that it takes time and you have to do the multiple steps are there. Otherwise it's very simple surgery and prognostically excellent surgery. So you have to detach all this muscle attachment, all the straps in as low as possible, all the muscles in the suprahyoid, that is attached to the hyoid bone, you release all the muscles. And you have to take decision regarding thyroid. What to do with the thyroid gland? Akash, what to do with the thyroid gland? Try to preserve both thyroid if possible, at least one thyroid if possible. Jodi involved thake, you have to remove all the thyroid, total thyroid. So try to preserve at least one thyroid lobe, and that thyroid lobe will be attached with which pedicle, superior or inferior? Inferior pedicle. Nothing wrong in preserving it in both pedicle. superior inferior দুটো pedicle preserve করা যায়, but preserving the inferior pedicle is easier because the laryngeal blood supply that comes from the superior thyroid artery. So you can ligate the laryngeal branch of the superior thyroid artery and preserve the superior thyroid artery totally. So detach all the muscles, mobilization, dissection in the carotid gutter for 2, 3, 4 neck nodes. Inferior constrictor muscle very important for reconstruction. So you release the inferior constriction muscle from কোথায় attach থাকে inferior constrictor? Thyroid to the posterior border of the thyroid lamina. So you release all the inferior constrictor on both sides and dissection to separate the tracheoesophageal party wall. তাই তো tracheoesophageal মাঝে একটা wall আছে, you have to separate it. Esophagus থেকে যাবে, esophagus you are not planning to remove, esophagus রাখতে হবে, tracheoesophageal party wall dissection করতে হবে কোন পর্যন্ত, যেখানে তোমার স্টোমা করবে তার নিচে যদি ডিসেকশন করো there will be necrosis of the esophagus. And the stoma creation এখানে হওয়ার পর you have to cut the trachea. কিভাবে কাটবে? বিভেল, তাই তো ট্রেকিয়াটা এরকম ভাবে কেটে দেওয়া যায়। সো বিভেল কাটছি সো দ্যাট অ্যান্টেরিয়ার ইজ স্মল পোস্টেরিয়ার ইজ লার্জ, এরকম ভাবে একটা বিভেল ধরেতে কাটা হচ্ছে, স্টোমা থাকছে। অবলিকলি ইনসাইজড, এখানে সে এই যে ইনসিশন দেওয়া হচ্ছে এটা এতটা হচ্ছে পুরো ট্রেকিয়া স্টোমা, আর এটা ল্যারিংসটা উপরে রয়েছে। দেন স্কিন সুচার টু দ্য ট্রেকিয়াল স্টোমা, তাই তো পার্মানেন্ট স্টোমা করতে হবে। স্কিন একটা সুচার দেওয়া হয় ওখানে ট্রেকিয়ার যেটা রিমেইনিং পার্ট থেকে গেল, একটা স্পেশাল টাইপের সুচার, কি বলে তাকে? কলিন ইজ ডিফারেন্ট, দ্যাট ইজ রিপেয়ার অফ দ্য ফ্যারিংস। এইখানে যে স্কিনটা স্টোমা যেটা লাগানো হচ্ছে দ্যাট ইজ হাফ ম্যাট্রেস, not full mattress, that is called half mattress. Half mattress suture, হ্যাঁ এগুলো করলে বুঝতে পারছি তুমি দেখেছো কিছুটা। সো there you have to create the stoma. Entry into the larynx, mobilize হয়ে গেছে কিভাবে larynx-এ or the pharynx-এ, sorry entry into the larynx, or sorry it should be pharynx, hypopharynx কিভাবে এন্ট্রি করবে? If it is endolaryngeal through the vallicula, মানে হাইওয়ার্ড থেকে এখানে কাটলে কাটলে you will go to the ভ্যালিকুলা, তাই তো হাইওয়ার্ড থেকে সব কিছু কেটে গেলে কী থাকবে? ভ্যালিকুলা। অ্যান্ড ইফ ইট ইজ দ্য আউট দ্যাট ইজ যদি দ্য ফ্যারিঞ্জিয়াল গ্রোথ থাকে, যদি দেন ইউ হ্যাভ টু গো থ্রু দ্য পোস্ট ক্রিকয়েড স্পেস। সো you can see it is, the larynx is removed, this is the permanent stoma and this is the defect after removal of the larynx which you have to repair, neopharynx, তাই তো ল্যারিংসটা বার করে দিলে কি হবে? ফ্যারিংস ওপেন হয়ে থাকবে, হাইপোফ্যারিংস। সো ইউ হ্যাভ টু রিপেয়ার দ্যাট থিং। এইখানে যে ওপেনিংটা রয়েছে এখান থেকে ফুট দিলে এখানে বেরিয়ে চলে আসবে নিচে ইসোফেগাস, সো ইউ হ্যাভ টু রিপেয়ার দ্যাট থিং টু ক্রিয়েট দ্য হাইপোফ্যারিংস। ইজ দ্য নেক ডিসেকশন সেম থিং, ল্যারিংস ইজ রিমুভড বাই ইনসিশন। আফটার রিমুভাল অফ দ্য ল্যারিংস কী করা হয়? যে কোনো ক্যান্সার সার্জারি আফটার রিমুভাল অফ দ্য স্পেসিমেন মার্জিন দেখা হয়, বেশ মার্জিন দেখে নিলে। নেক্সট স্টেজ কি? রিকনস্ট্রাকশন অফ দ্য রিপেয়ার। হ্যাঁ, তার মাঝে কি হয়? যারা ক্যান্সার সার্জারি করে তারা জানেন ইউ হ্যাভ টু চেঞ্জ, ইউ টেক দ্য রিপেয়ার সেট, চেঞ্জ দ্য গ্লাভস, হ্যাঁ, গিভ থরো ওয়াশ। সো থরো ওয়াশ গিভেন, নিউ রিপেয়ার সেট and change the gloves, nasogastric tube inserted and fixed, and primary TEP, তাই তো tracheoesophageal puncture, TEP মানে tracheoesophageal puncture for the voice, it may be primary or secondary. Secondary মানে wound heal করে গেল, তারপরে যদি রেডিওথেরাপি টাপি লাগে সব কমপ্লিট হলো, দেন ইউ গো ফর দ্য সেকেন্ডারি TEP। এটা আমাদের সৌমিত্রদা পড়বে। আচ্ছা অনেকক্ষণ তো বোর হচ্ছে, দেখি একটা 30 সেকেন্ড একটা ভিডিও দেখানো যায় কিনা, চলে কিনা যায় না আমি। সো এটা কি হচ্ছে? ইজ প্রাইমারি টিইপি, যেখান থেকে কাটানো হয়েছিল ফ্যারিংস, ওখান থেকে উই আর ইনসার্টিং আ প্লাস্টিক দ্যাট কামস উইথ দ্য ভয়েস প্রসেস সেট, ইউ আর ইনসার্টিং ইট অ্যান্ড ইনসার্টিং আ ক্যানুলা টু দ্যাট পার্ট. After insertion of cannula, you are passing a guide wire. guide wire and fix the guide wire with the valve and pull it out. So, this is the primary TEP and this is the voice prosthesis, Provox voice prosthesis. This is the primary TEP, খুব মানে শুনতে খুব বড় সড়ো লাগে কিন্তু জিনিসটা খুব কঠিন কিছু নয়। এখানে যেখানে তুমি প্রাইমারি স্টোমাটা করলে just go 10 millimeter below the superior margin and make a opening through the tracheal wall, through the esophageal wall into the esophagus. Tracheo-esophageal puncture, TEP. করে একটা ওয়ান ওয়ে ভালভ দিয়ে দিতে হবে so that air will come from trachea to the esophagus and food will not come. So, this is the thing after this is the patient after post laryngectomy, total laryngectomy patient. This is the Ryle's tube fixed. This is the permanent stoma, Glaxorinson incision. Can you say what is that line? Yellow Foley's catheter or any that catheter, anything, that red rubber catheter. Why it is inserted here? It is TEP. মানে পেশেন্টের প্রোভক্স ভালভ ছিল না, প্রোভক্স ভালভ ইউ ক্যান ইনসার্ট অন টেবল। আদার যে ভালভগুলো হয়, আমরা আদার যে কম দামি যেসব ভালভগুলো ইউজ করি, ইট ইজ ডিফিকাল্ট টু ইনসার্ট ইট অন টেবল। সো একটা টিপি করে রেখে দেওয়া হয়েছে, ইট উইল বি ম্যাচিওর্ড অ্যান্ড ভালভ উইল বি ইনসার্টেড লেটার অন। সো ডিসএবিলিটিস অ্যান্ড চেঞ্জেস অফ টোটাল ল্যারিঞ্জেক্টমি আফটার টোটাল ল্যারিঞ্জেক্টমি কী কী হতে পারে? টোটাল ল্যারিঞ্জেক্টমির পর কী কী প্রবলেম হতে পারে? ভয়েস চলে গেল, আর swallowing difficulty, আর smell, very good, smell. So voice, swallowing, smell and altered appearance. So all this needs rehabilitation. Dr. Soumitra Ghosh, he will describe this thing.
I think I am audible. So at the end of the day, all of you are overburdened, I know, with everything. My previous speakers have already done more than half of my job. I will go very short, very precise, exactly what is required for your exams. We know the functions of the larynx. Number one and the most important is the airway protection, respiration, followed by swallowing, and finally phonation that I am speaking to you. Can anyone name the first surgeon who had done laryngectomy? So it was Theodor Billroth. He removed the larynx. Now when he removed the larynx, the basic idea of laryngectomy was disease clearance. Today in the 21st century, after laryngectomy, again the primary thing is 100% disease clearance, plus we are equally vigilant about the quality of the life of the patient. So when the larynx is out, we have got some changes in the patient. We have got an altered airway dynamics, absence of voice production, changes in the swallowing mechanism and loss of smell. Just now we discussed all these four things. So today laryngectomy is done mostly for a neoplastic lesion of the larynx. So it removes the larynx and the adjacent lymph nodes and the soft tissues that we know. It is being done in a specialized center mostly by a dedicated team of surgeons. And these patients today require a very good amount of supportive therapy and support after the surgery, which is basically a multidisciplinary support. This multidisciplinary team includes the ENT guys, the anesthetists, the SLPs, the nursings, and in some cases, the pulmonologist and the physiotherapist. Okay, so we are focused on the rehabilitation after a laryngectomy patient. So we have got an open larynx in the neck. The first and the primary thing is the pulmonary rehabilitation. So the first thing is the pulmonary rehabilitation. So basically we have got a disconnection between the upper and the lower airway, and we have got an open trachea which is here. So anything can get into that. The first thing is you can just put in a guard in front of that. A very basic thing you get in everywhere, and you can even get it in Amazon today. The next is the conditioning of the inspired airway, and we need some amount of filtration and humidification. What happens when we have got an open larynx and the patient breathes out? There is a significant amount of loss of humidity and temperature, which is basically the function of the upper airway tract. So to come close to that, we can come up with these humidifiers. What these humidifiers do, when the patient breathes out, they retain some amount of humidity and temperature. So the next time when the patient breathes in, some amount of humidity, moisture and temperature is retained into the inspired air. And in some difficult patients, we may require some positive pressure ventilation, where we have got these specific machines like BiPAP. It's not required every time, but it may be required for some patients with a frail chest. And finally, when we go for this pulmonary rehab, we get reduction of sputum, cough and forced expectoration as well. So in these tracheostomy patients where they have got a tracheostomy tube, you can put in very easily available these filters and take care of the lower respiratory tract. The second is the olfactory rehabilitation. Why the patient does not get smell? Because there is no inspired air reaches into the olfactory mucosa, and the patient breathes through the neck, and the patient breathes through the tracheal stoma. So there is decreased taste, decreased food intake by the patient, decreased nutrition, and overall decreased quality of life. There is something called NAIM, or nasal airway induced maneuver, which is being taught by the SLPs to these patients. Usually they take, what they claim is they take around 30 minutes to practice this. I couldn't practice this myself. The basic thing is you make an extended yawn with your mouth closed, the lower jaw, tongue and soft palate and the base of the tongue and the floor of your mouth are depressed, so that some air gets in through your nose. The basic idea is to pull in some air like this through your nose so that it reaches that olfactory thing. So it is again something which is just like physiotherapy. Just for your exam purpose, if somebody asks, you can spell it out and you can try this when you are bored with your studies. The next thing is swallowing rehabilitation. The next major thing is the swallowing rehabilitation. Post-surgery, all these tracheostomy patients, these laryngectomy patients have a Ryle's tube put in. In fact, when I was resident, my boss would make it a point that when the patient is being taken to the OT from the ward, there is a Ryle's tube in situ. So these patients are on table with a Ryle's tube. After the surgery, after a total laryngectomy, it's a Ryle's tube feed for 10 days. At the end of the 10 days, we start with either liquid or puree, see whether there is any leak, because we have already refashioned the pharyngeal inlet. If you are in doubt, you can go in for a gastrographin test and see whether there is any leak. If there is a leak, you can wait for another 10 days time, or if you are happy with it, if there is no leak, just continue with liquid and puree diet. And swallowing therapy is the key at this stage, and you have to have a good swallowing therapist at your disposal who will counsel your patient before the surgery what is going to happen after the surgery. It is just not like taking away the appendix or the gallbladder and you are done. Encourage dry swallows. Even if in that first 10 days when there is a Ryle's tube, just encourage the patient to keep on dry swallowing, because we ask them not to swallow any saliva in the first 10 days and just spit out. Dry swallow happens to strengthen these muscles and cut down the edema by some degree, because when there is a foreign body like the Ryle's tube, it definitely inculcates or invites some degree of edema, mucosal edema. You have to keep in mind even the post-radiation edema, because even after the radiation is not started the next week. So even you have to keep in mind, maybe after 6 weeks or 2 months or 3 months when you start the edema, maybe the patient is not on Ryle's tube, but it may give rise to a significant amount of edema which can give rise to a worsening of the dysphagia. Cricothyroid myotomy versus cricothyroid myomectomy. During the surgery, all of us are taught to go for a cricothyroid myotomy. Studies have revealed that if you just detach the fibers, there comes back, it comes back again with fibrosis. So now what the surgeons are doing is they are removing a strip of the cricothyroid muscle so that the fibrosis is not that significant. Not just an incision, but just remove a strip of cricothyroid muscle. So there's the cricothyroid muscle and put in an incision. It may not be very identical with what we do, but just to give you an idea. And finally, for temporary purpose, you can try with botulinum toxin. You can inject botulinum toxin into the cricothyroid muscle to cut down the spasm. Because this is a very big thing that after the surgery, you have to give good nutrition to the patient. The most important part is probably the speech rehabilitation, which we are next to come in with. We know that the basic requirements of speech are active respiratory support, adequate glottal closure, normal mucosal covering of the vocal folds, and adequate vocal length and tension. When you are chopping off the larynx, you don't have the lower three things. So you are left alone with the active respiratory support, that is the lungs and the residue of the short trachea. So that is what we have left in our hands to give the patient an intelligible and communicable speech to live in the society. So what are the options? We have got a non-surgical option, we have got one surgical option. In the non-surgical option, we have got esophageal voice and we have got electrolarynx. In the surgical option, as Dr. Manoj Mukherjee has already said, there is the most accepted thing is the vocal prosthesis. Historically, something called the neoglottis was fashioned, but it is now out of fashion today. Esophageal speech. Almost all the total laryngectomy patients develop some degree of esophageal speech. The basics of esophageal speech is they insufflate air into the esophagus by swallowing it. Then they control it and force it upwards. So that we need some vibrating component to produce speech. So that the mucosa of the upper esophagus and nasopharynx vibrate, and this vibrating column is channeled through the articular apparatus. The only articulate apparatus left is the mucosa and the rest of the pharyngeal muscles. We don't have a vocal cord, a glottis or a supraglottis. There are two ways in which the patient injects air. One is injection method and one is inhalational method. All these are written in the book. This is just to give you an idea where you have to hit it. And this is again called something called a birth talking. Bangla bhasha যেটাকে আমরা ঢেকুর তোলা বলি, হাওয়াটা গিলে নিয়ে হাওয়াটা forcefully they will take it out. We have got something called a laryngectomy club in Calcutta where we had a good number of our patients post laryngectomy. The secretary of that patient, if you would talk to him, you would never feel that he had a total laryngectomy. So they used to train the rest of the laryngectomy patients to develop esophageal speech. Today in the 21st century, esophageal speech is probably not a very good option. Why we are coming to that? The second thing is the electrolarynx, the non-surgical part. Initially, they came out with something called a pneumatic device. There's a neck type which is battery operated, which is mostly used nowadays, and there is one intraoral type. It can be used in the initial stages when the patient hasn't developed any esophageal voice or tracheoesophageal voice. There is initially a good amount of hypoesthesia in this neck region, which can be a problem for the patient to use the electrolarynx. But the main disadvantage is, if you go to the YouTube, you see a good number of videos there. It is monotonous and the patient has got a robotic voice. The last part is the surgical technique. So yes, we still have a good number of patients who use electrolarynx, but they are quite a bit costly. The number one is the neoglottis formation, which we were taught by our professors when we were students. Today, neoglottis is probably not done in total laryngectomy. They used to do a tracheohyoidopexy where the trachea was elevated and fixed to the hyoid. The main disadvantage was aspiration, as there was no valve to cut down the saliva to get into the airway. So that is probably obsolete now. The next is the shunt technique, that is the tracheoesophageal fistula. As already discussed, we have got a primary thing that Dr. Manoj Mukherjee just showed you. We do it at the time of the surgery, and we have a secondary one which is done after 6 months of the surgery. The difference between an esophageal speech, and here is tracheo. This we can call it as a tracheoesophageal fistula, because we have got the whole lungs as the bellow of the harmonium to push the air up. So we have got more volume of air. We have got more pressure of air. But in esophageal speech, the patient only uses that much amount of air which he or she can swallow. So this extra volume and extra length probably gives a much better speech in tracheoesophageal fistula or these TEP patients. There is something called insufflation test. There are surgical challenges. All of these are written in the book. TEP can come as a short note or a long question. I don't think it will come as a long question. Insufflation test can come as a short note. There are some candidacies in whom you can do this TEP. There are some candidacy techniques who are not fit for tracheoesophageal fistula. Probably an extensive surgery is not a good candidate for a TEP, and yes, post-radiation cases, if you are planning for a secondary TEP, you have to think of whether you will put in the valve and when. Here we don't have time. Manoj, তুই তো সার্জারিটা দেখালি, I have got an animation. Do you want to see that animation of how TEP is done? This is taken from the net, I am telling you. This is just to give you an idea what we do it in our, I mean, Manoj has already showed you. This is a primary TEP where you have got this pharyngeal introducer to guard the mucosal damage. That is the trachea, that is the plunger. It prevents damage to the adjacent mucosa and soft tissue. And after that, this is the plunger, the needle which goes inside, through which you have to put in the guide wire to pull the thing from above below. So this is the guide wire that you put inside. It goes up, and through this you put in the yes. So you go through one way, come out through the other way, and there is that's the implant that we are going to put in into the tracheoesophageal puncture site, so that it allows one-way airway. And that's they are pulling it through the puncture site with a dilator, so that gradually it goes inside, and there it is in situ. So you go this way, rope it and pull it so that it goes in place. I think I have got just one more slide and we finish off. Yes, so the prosthesis can be basically of two different types. One is the indwelling one, which is being put inside by a medical professional like a doctor, or in the second or third stages by some company people, and the non-indwelling ones which are basically put in by the patient themselves. There are different complications like infection, mainly fungal infections. There can be leaks, there can be extrusions, based on which the designs are being changed from day to day. There are Provox, there are Blomsinger. You can come across all those names in your books. And again, this voice prosthesis is a short note, so you have to prepare for that as well. Basically, what happens is the patient closes the tracheostoma side from here, and the air goes up from here, and the patient speaks like this. So that's what we had to discuss regarding the rehabilitation. Apart from this, one of the major issues in laryngectomy patients is you have to counsel the patient and the family psychologically where they will stand after a total laryngectomy with no voice and everything. So we need support groups, we have to educate the patient, and that's how it goes. And today our motto again is to give the patient a cancer-free life, and parallelly to give them a good quality of life as far as practically possible for that patient. Thank you very much. Done for me.
Thank you. Just 10 minutes or 15 minutes lunch, then we will go for the osteology. Sir is already waiting. Dr. Subroto Mukherjee is already waiting. That is very interesting for you, and that's